Thanks, Guido. This was almost a sudden surprise for me when I was asked to talk about complicated urinary tract infections and how to prevent and treat them. I've tried to give it an endourology and stone flavor, going with the rest of the talks this morning. This is from the EAU, the guidelines, the urinary tract infections, uncomplicated, which could be cystitis, pyelonephritis, or recurrent, and then complicated, which could be high risk and urosepsis, or a combination of any of these. So catheter-associated infection, or male UTI, or recurrent infections, pyelonephritis. So just to purely define it, uncomplicated is an infection in a healthy patient with structurally and functionally normal tract, and complicated is associated with increasing risk of acquiring bacteria and decreasing efficacy of treatment, so structural and functional abnormality or host compromised or bacterial virulence. And when you look at the classification, by definition, men, pregnancy, patients with abnormalities of urinary tract, indwelling catheters, or other immunosuppression is all complicated. And similarly, apart from that, people who have got healthcare-associated infection, foreign body, or recent instrumentation, again, it's complicated infection. A little bit about asymptomatic bacteria, because this is very important and we all deal with it all the time. You have no symptoms, but there is bacterial growth. So for these patients, you probably should monitor residual urine, but they don't always need cystoscopy or upper tract imaging. However, if there is proteus, you need to look for stones or exclude stones and always do a DRE, a rectal examination in men. When again we talk about asymptomatic bacteria, you have to screen for pregnancy, but don't screen for females without risk factors or just because the patient are immunocompromised. You don't have to screen for them. You must screen in pregnancy, and in these cases, you have to do the urine culture and then treat it, or in patients who are going for an endoscopic urological procedure, you should screen them. The prevalence of bacteremia varies, but it starts from around teenage, and then it increases with the onset of sexual intercourse. But when you look at symptomatic infections, generally, it is gradual for females, and in males, it starts with the problems starting with the prostate and enlarged prostate and issues relating to emptying the bladder. So when you talk about asymptomatic bacteria, treatment is not always beneficial for just because it's there. You don't have to treat it. You treat it, if you just treat for anyone, it's actually more harmful. So you must treat for patients who are pregnant or for before any procedure. And what about treatment? What do you treat with? So antibiotic treatment would reduce symptomatic infection in pregnancy, and they should be screened and treated. But what treatment should you give? The short course is recommended. So 2 to 7 days of antibiotic treatment is what is recommended as a treatment. Symptoms, we all know about symptoms of urinary infection, but if it's complicated UTI, you can have acute pyelonephritis or sepsis or catheter-related infection. Again, uncomplicated cystitis, you should probably not do a urine culture in all situations, but you should do it if you suspect pyelonephritis, or they've had recent infection and they've had a recurrent infection, or the symptoms are very atypical, and you're not sure. When it comes to diagnostic evaluation, ultrasound should be done in these cases, but additional imaging you only do if after 3 days of treatment, the patients are still not better. So you've given them treatment for 3 days, but it's not resolving, then you must think of other modes of imaging. And again, you have to keep in mind about protocols and guidelines, but also stopping treatment once the course is finished. So don't give unnecessary treatment, give a short course if recommended, and stop when needed. And for selected cases, do a urine culture. This is a recent paper that has been published. What is the effect of fluid intake in premenopausal women with recurrent infection? And they had 2 groups, 1.5 liters of water or control group with no additional fluids. And it was clear that people who were drinking at least 1.5 liters of water were much less likely to get a symptomatic infection. So increased water intake prevents recurrent cystitis in premenopausal females. We have all heard and talked about cranberry. This is the most recent Cochrane review, and the bottom line is that cranberry cannot be recommended for urinary infections. It might work for some, it may not work for some, but the review conclusion is that you cannot recommend it as a standard treatment for urinary infection. What are the principles of treatment for complicated infections then? You manage the complicating factor or underlying factor, optimal antimicrobial therapy based on the culture, and duration is usually somewhere between 7 and 14 days. It's probably longer if they've got blood culture positive infection, but otherwise between 7 and 14 days. And the guidelines say that if the resistance for an uncomplicated UTI is less than 20%, then you can give. So for example, if you want to give ciprofloxacin as an example, if the resistance in your area is more than 20%, you shouldn't be giving it. For complicated infection, it's 10%. If in your area the resistance is more than 10%, you shouldn't be giving that drug. So choose antibiotics based on local susceptibility. If you have got complicated UTI, the recommendations are if they have symptomatics, if they are really unwell, they need hospitalization, and empirical treatment that we sometimes give must include cover for ESBL. Catheter-associated infection is also complicated infection, and this is usually happening in people who have had an infection either within 48 hours or who have a long-term catheter. It contributes to 20% of all hospital-acquired bacteremia, so it's quite common, especially in elderly. 10% of mortality, and the rates of bacteria vary between 3 and 8%. The most important risk factor is the duration of catheter. So the sooner the job is done, get the catheter out. And the recommendation for treatment is similar to the complicated UTI. So treatment is necessary if they're unwell, if they've got recurrent infections. Always take a urine culture in these patients and treat asymptomatic bacteria only if they've had trauma to the urinary tract, not otherwise. And replace the catheter. Do not routinely give antibiotic prophylaxis to prevent infection after removal. So when you're removing the catheter, they don't need an antibiotic for that. But when you're changing it, if you've got an infection, always change a catheter and then give antibiotics. I think this is variable. This depends on the local, what is the local prevalence. I don't think in our hospital, for example, for catheter infections, we normally give gentamicin as a first line and then some other antibiotic depending on the resistant pattern. But again, if the resistance to ciprofloxacin is more than 10%, you should not be giving ciprofloxacin to these group of patients. And manage any underlying abnormality. So if they've got an issue, if they've got bladder stone, for example, then you have to manage it. Otherwise, it's not going to settle down. So if in a catheterized patient, just because there's a bit of smell or it looks cloudy, it doesn't always mean there's infection, because it could just be sediment and debris. And the slight difference is the microbial growth of more than 10 to the power 3 or more than 1,000 colony-forming unit is enough to say it's an infection. And pyuria is not an indicator. So if just because there's a bit of pus or a bit of cloudy urine, it doesn't always mean there's an infection. So antibiotic prophylaxis for other procedures, you do not need to give it for urodynamics or cystoscopy or as well. You do not need to give routine antibiotics. For ureteroscopy, use antibiotic prophylaxis. I normally give it once only, just before induction of anesthesia. You don't have to give any long course. Again, for PCNL, single dose of antibiotic. For TURP, again, you need to give antibiotic prophylaxis. And for bladder tumor, for high-risk ones or large bladder tumors, you need, similar to TURP, for very small ones, you don't always have to give it. And these are the recommendations. Urosepsis is something that we all are afraid of, we are scared of, and we need to avoid it. But what if it happens? How do you quantify it? How do you measure it? There is something called as a SOFA score, or Sequential Organ Failure Assessment Score. Mainly, it's got three things: altered mental status, respiratory rate, and blood pressure. And if you've got three of these, then you score the patient, and higher the score, the more unwell they are. If you've got urosepsis, you need to perform this. Just make sure they are, it is urosepsis. and take a urine and blood cultures, and then administer antibiotics without waiting for the culture results. Initially, you give high-dose antibiotic, whichever one is your practice. So in our hospital, for example, if you've got a urosepsis of unknown origin and they're really unwell, the recommendation is vancomycin until proven otherwise. And you can combine it with some gentamicin depending on the renal function. But different hospitals will have different protocols. This is just a generic guide. I don't think we can prescribe that. It's individual hospital guidelines or individual regional guidelines for these. How do you prevent infections from hospital-acquired infections? You isolate them. If patients have got multi-resistant infection, they should be in a side room. Reduce hospital stay, remove the catheters early. The catheter should be in a closed drainage bag so that you're not having to empty it, and general asepsis. Now, this is what I'm talking about regional. Your trends of antibiotics are based on your own outcomes and results locally. So we looked at our antibiotic resistance patterns for 5 years just for E. coli, and this is what we found. So the blue line at the very bottom is trimethoprim, is nitrofurantoin. So in our hospital, or in our setup, nitrofurantoin had the least resistance to infections, and we give it routinely to all female UTIs and people with normal renal function. But because it doesn't have prostate penetration, you can't give it in the same way to males. The next one up, the light blue, is gentamicin, and so on. And green and orange are trimethoprim and amoxicillin. So we probably don't, it's toss of a coin. It's 50% resistance. It's no point of giving them in the hospital. So that's why you need to look at your local patterns. And then we revisited that with more than 100,000 positive urine culture. And this luckily showed that the patterns are very similar. They hadn't changed. So we looked at in 2011 and did it again in 2016. Our patterns are very similar. And it's important to know your local patterns before you give antibiotics, because if the resistance is high, then that drug is not going to work, irrespective of what the guidelines say. This is something, again, as I said, it's a stone flavor to it. So this is something, what happens when people have urosepsis and they have initial drainage? They then need ureteroscopy, or they need a procedure. So we looked at 82 procedures in our series of patients. Most of them had stents, some had nephrostomy, but a third of them were in ICU at the time of drainage. So they were so unwell when they had admitted, they went straight to ICU. We looked at elective outcomes of ureteroscopy, and stone-free rate was quite high, length of stay, most of them were again day cases. But the complication rate, we had 3 complications, 2 urinary infections and 1 sepsis. And this just goes to show that if you've got a good antibiotic protocol based on the local policy and the local resistance, no matter what the guidelines say, you need to know what is prevalent in your area. And based on that, when the outcomes of these people who had sepsis to begin with is very good. This is something which is new, not many people use it. So if people have got recurrent infections, infection after infection, you've done everything else, is there a role for intravesical antibiotic treatments? Is there a role for intravesical gentamicin, for example? So we looked at a review. We also do it in our setup, but we looked at a review, and there was a symptomatic reduction of UTI in 78% of cases. So these are patients who are end of line. You've tried everything else. Nothing is working. If you give them intravesical gentamicin or alike, it was shown that these patients can respond. 4 out of 5 patients will respond. The slight issue was the long-term follow-up was not there. But in the short term, between 6 to 12 months, they respond. And there's divided into treatment group where the success was 88%, and prophylaxis group where you have people who you are giving it as prophylaxis, and the success rate was slightly low, but still 71%. So for treatment group, people have used gentamicin, colistin, neomycin, and prophylaxis, again, gentamicin most commonly. And it showed that single installation of gentamicin, diluted in saline, given in the bladder, and then you ask the patients to hold on for as long as they can, and you can repeat it in cyclical. So in our setup, we give them weekly, and you can give it for 4 to 6 weeks, and then leave it. And we also culture them. Has the culture trend changed? And it showed that overall, this is not a bad treatment when there is nowhere else to go. This is like the very end. What else do you do? And finally, this has just been published. This is in Journal of Urology. You have treatment, recurrent infections in females. You stratify them into postmenopausal UTI, premenopausal but related to coitus, so postcoital infections, and then premenopausal recurrent infections. And what they found in postmenopausal, there's a big role for topical estrogen or probiotics. In premenopausal, you need to consider low-dose antibiotic about a couple of hours before the sexual intercourse. And if there is no other issues that you can identify, maybe there's there's a role for lactobacillus or probiotics. And for premenopausal recurrent infection, where there is nothing else, you need to consider low-dose daily antibiotic. So we all use it for some patients where there's nothing else you can do, a low-dose daily antibiotic. But looking through it, you have also got to identify the high-risk patients and deal with them. Thank you.